So, to understand the pathology, the physiopathology of acute lymphoblastic leukemia, we need to understand the principles of cancer, right? Um, let's suppose that this is going to be a lymphoblast. So, it's an immature cell, but this cell it's going to have a nucleus. This nucleus it's going to have a genetic material. uh, this genetic material is going to be relevant for the production of proteins. Also, we're going to have these cell growth factor receptors that can be activated and generate a cascade with transmembrane proteins to activate transcription factors. What the transcription factors activation does is that they start reading the genes, right? And they read it and they can form proteins by doing this, uh, thereby initiating the releasing of proteins that can induce the cell into the G1 phase in the cell cycle. These proteins are cyclins and CDKs. Also, we're going to have another types of proteins that can induce uh, proteins for cell arrest. So, stopping the cell to grow, right? And also, we're going to have proteins for repairing the DNA that it seems to be damaged, right? And also, we're going to have proteins that can induce uh, the apoptosis, so cell death, right? The thing with acute lymphoblastic leukemia is that there are multiple steps in which this immature cell can continue to divide itself even when it's not mature. And how it does it, it's by with uh, mutations that gives us another conjugation of proteins and induce the cell to start the cell cycle in the G1 phase, or, and not stay in the quiescent state, right? This is why we have deaccelerated growth of immature form of the lymphocells, right? Lymphoblast. Okay, so how we're gonna diagnose an acute lymphoblastic leukemia? First, we can start asking for a complete blood count, where we are gonna see a decrease in red blood cells, decrease in platelets. White blood cells, they can be either low or high, right? On a peripheral blood smear, we're gonna high increase in lymphoblasts. Also, the definitive diagnosis is gonna be made by bone marrow biopsy. This study has to be with a 20% higher of lymphoblast cells. Also, we can ask for immunophenotyping or immunohistochemistry. The TTT, it's going to be a positive uh, diagnosis. Also, we can ask for flow cytometry. In this study, we evaluate what type of cell it's affected, right? So if there are CD10, 19, 20, we can talk about a B cell lymphoblastic leukemia. But if it's a T cell, we can see the CD2 and CD8. Also, we can ask for genetic studies to evaluate mutations or translocations, and the testing for leukemic infiltration. In central nervous system, we can ask for a CT or MRI. In lung infiltration, a CT, chest, or radiography. Also, for testicular infiltration, we can ask for ultrasound. In liver, we can ask for a ultrasound or a CT in abdomen. Okay. We're going to review the treatment for acute lymphoblastic leukemia. Chemotherapy is going to be very efficient between children. So, um, first, we have agents, chemotherapy agents, and the first step is to eradicate all these blasts, right? Um, to less than 5% of the blood count. The first stage, it's called the induction stage, and the goal is to uh, end up with a normal hematopoiesis. The second stage is a consolidation, and it starts after complete remission. And the third stage is maintenance, and it's after remission 1 to 2 years after, and it's with less intensity. Also, we have another type of chemo, the intrathecal chemotherapy for meningeal leukemia. This in this type of chemotherapy, we can also add radiation. To understand the mechanism by which some agents participate in the interruption of this deaccelerated growth of cells, immature cells, we have the vinca alkaloids. Vincristine will use chemotherapy agent for uh, ALL, and what it does, it binds to tubulin, which doesn't allow the cell division in the M phase in the cell cycle, generating a cell death in the cell, thereby interrupting the growth of this immature and mutated cell. Another advanced therapies are um, tyrosine kinase inhibitors like imatinib, which it's well used in translocations like 922, and also when these therapies, all past mentioned, are not efficient, we can recur to the bone marrow transplant. There can be some complications after treatment with chemotherapy in acute lymphoblastic leukemia. The first one is the chemo brain, also described by patients like mood changes. Also, there can be ulcers or mucositis. This because chemotherapy agents it's affecting to rapid cell division cells. So epitheliums, mucosas are rapid dividing cells, right? It's not just a specific for cancer cells. We have other cells in our bodies, healthy cells, that divide themselves rapid, and there's nothing wrong with them. Also, we can have a simulation of vomiting center, diarrhea, and constipation. By the same affecting mucosa, the skin and nail changes. Neuropathy can also be referred by patients. In the gonadal dysfunction, in women's, it's going to be seen like anovulation, and premature menopause. In men, there can be a decrease in the spermatogenesis. In the bone marrow, besides this clinical sign of bone pain, there it's going to be also a myelosuppression because it's not going to be a specific. All of this it's already present in ALL, but it's going to be aggravated after chemotherapy, right? We can use antibiotics for neutropenia. For thrombocytopenia, we can use transplant platelets, and for anemia, blood uh, transfusion. Also, it's important to mention that alopecia it's going to be present or has a secondary effect of chemotherapy. And chemotherapy it's going to affect target cells with a high turnover and rapid division. And the most important complication is the tumor lysis syndrome. This occurs because it's going to be a large amount of cells that are getting into the apoptotic stage and thereby releasing a lot of material that can lead to a toxic stage to the patient. Also, other complications include infections, reaction, anaphylaxia to the same. Also, bleeding or of thrombosis can be complications, important complications in the patients after chemotherapy.